Hello, a big warm welcome to all of you. I'm Dr. Archana Upadhya from India. I'm going to speak on Bioelectronic Medicines Revolutionizing Healthcare. So, bioelectronic medicines are neuromodulatory electronic devices because dysfunctional neural circuits give rise to dysfunctional organs, and bioelectronic medicines use electrons to manipulate electrical signals in vivo. And the goal of these medicines is to restore healthy patterns of electrical impulses, to adjust how neurons fire, and thereby changing the concentration of neurotransmitters which travel down circuits. There are many applications of bioelectronic medicine. So the three main applications are: one is they can be used as prosthetics that replace or improve impaired sensory, motor, or cognitive neural functions, retinal prostheses, auditory implants, for therapy for treatment of epilepsy, depression, Parkinson's disease, and in research to investigate how neurons and neural networks work in the central nervous system and the peripheral nerves. Coming to retinal implants. Now, retinal implants will be beneficial only to those patients which have the this inner retinal nuclear layer intact. So these layers have to be intact, and the processes which lead to the brain, to visual cortex, need to be intact. Only those patients who have retinal pigmentosa, retinitis pigmentosa, and age-related macular degeneration, who do not have this retinal outer nuclear layer is disrupted or degenerated, they can benefit from the retinal implants. So retinal implants are positioned in three locations in the retina. It could be epiretinal implant, which is where it is placed on the limiting membrane and contacts the inner retinal nuclear layer. It can be subretinally located in place of the photoreceptor cells which have been degenerated. It can be located in the region between the sclera and the retina, the choroidal region, suprachoroidal region, and the intrascleral region. So coming to the most popular implant, which has been implanted in more than 350 patients, which has been discontinued because the company closed down, is the Argus 2 retinal prosthesis system. So here this is an image. Here we have shown the image of an apple, which is this image is captured by a camera, and the visual images are sent to a video processing unit, which converts these visual images to electrical signals, and these electrical signals are then transmitted, are then taken, you then take them back to the wireless transmitter which is present on the Argus glasses, and the wireless transmitter wirelessly transmits the electrical signals to a receiver, which then carries them to electrode array, and the electrode array then stimulates the inner retinal layer, and then these impulses are then carried down the optic nerve into the visual cortex. In case of subretinal implant, they don't require the external processing unit because they directly convert the light to electrical signals. So these are done by hundreds of photodiodes which are placed on the retina. So alpha IMS is around 1,500 photodiodes. These they are connected to the receiver, the transmitter, and the benefit of this is you have a handheld device where you can decrease the brightness, or you can switch on and switch off the device. In case of the subretinal implants, this is closer to the inner retinal nuclear layer, so you have less stimulation is required to send the visual impulses uh, via the optic nerve to the brain. So, that is the advantage of this, and have the suprachoroidal implants which are positioned between the retina and the sclera. The disadvantage is they are placed at a larger distance away from the inner nuclear layer, so the stimulation required is greater, and this can cause a wider distribution of current and cause off-target effects. So that has to be perfected on. Here the system is same as Argus. A camera captures image, transmitted to external body bone processing unit, video processing unit. The data is processed and sent to implanted system via an external wire, same like the Argus, and then sent to a receiver. The receiver sends the electric impulses into the implant, and the implant stimulates the inner retinal nuclear layer. So how do the patients perceive images? So images are perceived as monochromatic dots or phosphenes. They don't receive a clear image as we do, as we receive normally, because we have millions of rods and cones in the healthy retina, and we get a megapixelated image. Here, because the number of electrodes are few, in case of Argus it's 60, in case of the IMS 1500, so we do not get a very clear image. But some light perception is received by the patients, and they can, depending upon the electrodes, photodiodes electrodes on the implant, the type of stimulation, the position of the implant, the shades of grey that can be interpreted by the patient. Some vision can be obtained as seen here in the work. So these can read very large letters. Small letters cannot be read by these patients in spite of the prosthesis. This is an overview of all the prostheses which have been used in clinical trials. And among these, the subretinal implants give a better performance. All the patients didn't give the performance. Some patients, the best visual acuity seen in some patients was 20 to 546. This is much less compared to a normal vision, which is 20/20. Some of them are still under investigation. The Osaka group is investigating the intratranscleral devices, and the alpha AMS. You have other alpha AMS, though is discontinued now, but you have other epiretinal implant systems which are being investigated for as retinal prosthesis. The Prima, Iris, all of these are being investigated. Coming to the auditory implants, now this auditory implants, we are not going to include the normal hearing aids which amplify the signals. We are going to check about those implants which are implanted and which modulate the neural signals, so which stimulate the nerves. So here you have the cochlear implant, which is implanted in the cochlea in those who have sensory neural loss, indicating that how do you identify these patients? These patients cannot hear with the best hearing aids. So either there's a loss in sensory neural system in the cochlea, or it could be a loss of the auditory nerve. So usually auditory nerve is auditory nerve which is being impacted in non-congenital patients is when they have neurofibromatosis. It's a brain tumor which and removal of the tumor causes disruption of the auditory nerve systems. So in those systems, you need a auditory brainstem implant where the electrode is directly stimulated. Electrode directly stimulates the brainstem area. The cochlear implant you use only on those patients which have intact auditory nerve. Coming to the cochlear implant is being widely used. It consists of a transmitter, microphone, and speech processor, and internally to that you have a transmitter and a receiver, from where you have these the signals are transmitted to the electrode. The electrode in turn excites the auditory nerve fibers, and it's sent to the speech area in the brain, the auditory region in the brain, and then the speech is perceived. Speech and auditory, the noises are perceived. So here, this is how the cochlear implants look like. All of these are marketed cochlear implants: Nucleus 22, Nucleus 24, Freedom, Hybrid, Nucleus 5, Nucleus 6. So these are all generations of cochlear implants. The auditory stem brainstem implants. Here also you have a transmitter called microphone similar to the cochlear implants, and a receiver stimulator. The difference is in the electrode array. You don't have a curved electrode array. Your electrode array is directly placed in the brainstem, bypassing the inner ear systems. So this is here. This electrode has 21. This electrode array has 21 electrodes. Another, this was artificial basal membrane. So this was thought to replace cochlear implants because because of several reasons. They felt that this was a better alternative to cochlear implants. But here the problem is the basal membrane, artificial basal membrane is created, but the impulse which is generated are weaker and they don't stimulate the auditory neuron. So this has to be improvised before they are clinically used. Now they're not being judged under investigation. Coming to deep brain stimulators, now this deep brain stimulators are the electrodes which are placed in the brain and which have the leads take them to a internal pulse generator, the IPG, the implanted power source, and this can be this is also programmed. You can program the frequency of the stimulation through externally through a computer. This can be done by the doctor, and so it's approved for Parkinson's disease, essential tremor, dystonia, obsessive compulsive disorder, medically refractory drugs, epilepsy, and it's being under investigation for various other diseases as well. Their work. So electrical effects of deep brain stimulation is they alter the efferent motor response, they alter the receiving efferent motor response and efferent sensory stimuli. They they interfere with the orthodromic anti-antidomic action potentials. They can modify the blood-brain barrier permeability, and they can modify the neural environment in the brain. And as far as molecular effects are concerned, they cause release of several cytokines which can have neuroprotective effects. Dopamine is also released, which is useful in Parkinson's disease. Norepinephrine is released and serotonin is reduced. So these are some of the molecular effects of deep brain stimulation. Then we have the vagus nerve stimulators. Now vagus nerve is a very interesting nerve. It's a mixed nerve. It contains of 20% efferent motor nerve fibers and 80% afferent sensory fibers. It innervates a lot of organs. The larynx, the esophagus, the lungs, the heart, the digestive system, and the nucleus tractus solitary, which controls the respiration as well. And there are different categories of vagus nerve stimulators. The invasive vagus nerve stimulator, where you have the left cervical vagus nerve based implants. So these have been approved for refractory epilepsy, treatment-resistant depression, and the right cervical vagus nerve implant, which is implicated in, which is being studied for clinical trials are going on to see whether it is useful in congestive heart failure patients. Non-invasive vagus nerve stimulators are more popular. You have the transauricular vagus nerve stimulator, which is being studied for major depressive disorder, inflammation, insomnia, pain, primary headache, migraine, and refractory gastroparesis. And you have selective vagus nerve stimulators, where only some. This is also an area which is undergoing a lot of investigation. One more thing about vagus nerve which has excited scientists is vagus nerve has also been implicated as an activation of vagus nerve sort of triggers an anti-inflammatory pathway. So many inflammatory diseases like Crohn's disease and maybe sepsis, they're still investigating whether they can reduce sepsis by triggering the vagus nerve. And so many of the pro-inflammatory cytokines like TNF alpha, IL-1, IL-6 are reduced on vagus nerve stimulation. So this is the cholinergic anti-inflammatory pathways on stimulation of vagus nerve. So you have the splenic nerve, and then the T cells, the acetylcholine is released, and you have the pro-inflammatory cytokines which are reduced, and this reduces inflammation to a great extent. So anti-inflammatory mechanisms are three: the hypothalamic pituitary adrenal gland axis, the cholinergic anti-inflammatory pathway, and the non-neural link between the vagus nerve and the spleen. So all of these can reduce the inflammation which occurs. So they are investigating vagus nerve in case of inflammatory diseases. So this is a currently very interesting application of vagus nerve stimulators. So these are mainly the evolution of the vagus nerve therapy system. So you have the first plant is implanted with VNS technology in 1988, sorry, and then all of these are devices which have been approved by FDA for treatment of drug-resistant epilepsy and for difficult to treat depression. So still a vagus implant, now vagus nerve near the cervical, left cervical vagus nerve implant has been used in many patients, and it has been approved for use, and several have benefited from it. And then you have the transcutaneous vagus nerve stimulation, that is the stimulation which does not require, which is non-invasive. So here the ear region is stimulated, is innervated by cutaneous auricular branch of the vagus nerve. So you have the tragus, the cavum conchae, the simba conchae, the antihelix. So these are innervated by ABVN, and in the neck regions are innervated by the cervical branch of the vagus nerve. So these can be stimulated. The neck region can be stimulated by the gamma core device, which is used for migraine. On the left side, of the vagus, left side of the neck. Then you have the earlobe, shaman, simba, concha stimulation. These are Nemo's electrodes. The external ear and the concha stimulation is done shown here from TENS device. So this is a tragus stimulation. This is like a headphones. This is a headphone, like headphones with their nervous vagus nerve stimulators. Net 100, and the concha and the simba active stimulation can also occur. All of these can be used to stimulate the vagus nerve and to reduce the anti-inflammatory effects in case inflammation is prevalent in the patient. And for mainly this is used for migraine attacks, the gamma core device. Coming on to selective VNS now, vagus nerve contains bundles of fibers that vary in diameter and conduction velocity. These fibers activate in order from their size, from the largest A fibers to smallest C fibers. Since vagus nerve stimulator is not selective, it's associated with several side effects because of activation of off-target nerve bundles. So side effects seen in long-term treatment of VNS are cough, voice alteration, dyspnea, pain, paresthesia, headache, pharyngitis, depression, infection, and death. So there are two approaches to get selective vagus nerve stimulation, where you can selectively stimulate one of the fibers you can exploit, because all of these fibers have different activation thresholds, and then or you can have spatially selective, where only a portion of the vagus nerve is some portion of the vagus nerve is stimulated to activate only selected fascicles. The spinal cord stimulator is the next device which I'll be talking about, bioelectronic medicine talking about. You have epidural spinal cord stimulators which have been indicated for pain, vascular pain, rachidial pain, chronic regional pain, where you have the needles inserted into the epidural space, and then it is being the signals are sent to it, electrical signals are sent to it through a external device, and this is it has to be carefully inserted not to disturb the spinal cord. And they're further investigated for treatment of heart failure, spinal cord stimulators for Parkinson's disease to repair the gait of the individual, spasticity, spinal trauma, rehabilitation. Transcutaneous spinal cord stimulators are also being looked at increasingly because these are non-invasive and usually they are favorable. Non-invasive bioelectronic medicines are usually looked at because they are favored because there's less of foreign body reaction. We'll come to that now. So foreign body reaction of the host to a external device. So here's an example of a bare biomaterial surface where you have, as soon as inserted, you have protein deposition. Depending on the type of protein which has been deposited on the device, you have neutrophil recruitment, monocyte recruitment, and then the differentiated macrophages because they see it as foreign, and the body wants to engulf it and destroy it. So this leads to foreign giant body formation. Finally, the body gives up and tries to encapsulate this in a fibrotic capsule. So when it does that, the efficiency of the bioelectronic medicine reduces, and the stimulus is not adequate. There's a lot of resistance to electric signals. So all of these happen when you have the foreign body reaction. If it starts with acute foreign body reactions and becomes chronic inflammatory reactions. So this is a small chart where they have studied various implant material with respect to the implantation period and the fibrotic area around the implant and the animals which they have investigated in. So, and the nerve tissue and the fibrotic, what happens to the nervous tissue? Is it regenerated? It is reorganized? Does it benefit from these type of implants in the bioelectronic medicine, or they fail to give adequate performance after a particular period of time due to the foreign body response? Bioelectronic medicines and clinical trials. There are some of them, and they are mainly used for vagus nerve stimulators are used for treatment of inflammatory diseases. As I said, this is an upcoming application of vagus nerve stimulators. Spinal cord stimulators are being investigated for chronic pain. Electronic medicine is a $2.6 billion market today and is predicted to exceed the $16 billion in 2029. The market for retinal implants and vagus nerve stimulators will far exceed the CNS stimulation and cochlear implants. That's been predicted by some. I mentioned this in the paper, and the citations have been mentioned from where this has been lifted. Now, smart systems where the devices equipped with artificial intelligence are popular in development, because this device could gather and store information, neural activity of the patient, which will enable a caregiver to customize the treatment and also help us to get information about the neural network efficiency, or the neural network, the science behind the neural network, and we could do a little bit more research. Research on the neural networks would be facilitated using a smart device. Sensory prosthetics. So we wrote this an integral neuromodulation part of electronic device. My student, Dr. Sita's student, Ms. Ifsham Ezekar, and myself, we all get together and wrote this article. And thank you for your attention. And I look forward to your questions.